So the topic, I just want to thank both Jody and Leanne about with their talks. It was fantastic to get that update. And interestingly, I actually don't have the slide from Jennifer Temmel's study in my slide deck, which is interesting. I have another study that she is involved in, but by one of her counterparts that's in part of this. But she's very, very well known in this field. I want to thank them. I want to thank, one thing I meant to say earlier is I want to thank all of you that are here, mainly because it's very interesting and amazing to watch how many lives are touched by the group of people that were here this last few days. Pretty impressive. Thousands, hundreds of thousands potentially of lives that are touched by each one of you. And it's pretty amazing. And I think that sometimes we maybe don't realize the impact that we have on people's lives and how significant that is. And really, Jody explained, and I'm sure, Leanne, you've been in this situation when you show up in a patient's room and something that you say doesn't go well, it really is challenging. So I appreciate this opportunity to have our group talk about some of these things. First, when is it appropriate, like Leanne talked about, just when should we be involved from a palliative care standpoint, and then how? How do you do that? And I greatly appreciate Jody's tips on how to do this and what kind of things to say. Loved learning that. So the slide or the topic that I plan to talk about is called Palliative Care Co-Management. I guess it's probably a simple term for how do oncologists and palliative care providers work together. It's pretty simple. And interestingly, with most of my slides, I guess first I have to go through the disclosures. I do not have any disclosures other than the fact that I am not an oncologist. So there are a couple of cases here that may or may not have some made-up pieces to them. So bear with me. Don't highly scrutinize. I know all the cases that we listened to over the last 2 days were highly technical and very exact. I'm not an oncologist, so that's that. And I actually start out usually by gathering demographics, which is interesting. So I'll start with myself. I mean, both of them described who they were. I actually work in Boise, down south about 8 hours, and I work in a situation that's quite interesting. Similar to what Jody mentioned, is I do inpatient palliative care and I do outpatient palliative care, both. And I do some hospitalist work, so I'm kind of in the middle of that group. But I mainly, it's just interesting to describe what I work in. So our hospital system created a clinic that has a big palliative care team, and each of our visits are at least 2 hours, maybe 3 hours with the patients, and it's quite an interesting scenario. So I'll get into a little bit more about that as we talk through this. But I also want to get the demographics of the group, and I know this is harder because we're on a recorded system. But mainly, and I should have done this in the beginning for your benefit, so I apologize. I meant to do this, but I actually would just want to raise of hands who are physicians in the group that's still here. Okay, so there's a handful of physicians. What about nurses? Okay, and I assume usually nurses are kind of the oncology nurses that do everything for the physicians. Is that right? Is that how it's described? That's and then any social work or anybody from the social work realm. Any others that are here? Nurse practitioners. Sorry, I've failed to mention that. That's a very key group that does a lot of work in this realm and in the palliative care realm, both. So let me ask this: how would you describe you have high level of access to palliative care in your community? Anybody that can raise their hand to that? Maybe one or two. Okay. Could you describe what that access is? Do you have access to physician, nurse practitioner? What kind of group do you have access to? Okay.
Physician and nurse practitioner.
Good. Okay. Good. All right. And then the others that didn't raise their hand, do you just not have palliative care available at all, or what is your scenario?
Some inpatient, nothing outpatient.
Okay, which is actually quite common. I think it's a very high percentage of areas that just have inpatient palliative care, which is a goal that our group and our specialty is trying to overcome, which is why, Jody works in a clinic some, I'm now able to work in a clinic some, but not every place has that available. So hard to see and hard to figure out how to manage this. So that's helpful from a demographic standpoint. And then I also, and I won't do this today, but I also, unless you have something that's just burning in your mind that you really want to make sure is answered today, I usually actually start with the questions that the group has, because it helps me direct my discussion to those questions that the group is experiencing. I know that we've had great discussion already and great information. Are there any particular burning questions that I know we'll have time to answer, but before I finish, is anything that you're just like, when you see this topic, co-management, what comes to your mind? Is there anything you want to hear? Anything in particular? No? Just want to hear about it? Go ahead. Approach to what? Oh, great. That's a great question. Okay, I'll try and put that in here in part of these cases. So thank you for bringing that up. It's also a hot topic in palliative care and in the general community with all of the things that have been happening with the opioids, with the FDA and things like that. So good. So let's move on. So a couple of the questions that I have, this is some of the responses that we were planning to have, but when is palliative care appropriate? We kind of already got a little bit of that answered. At diagnosis of a serious illness, throughout a serious illness, only near the end of life, for chronic pain, opioid management, you just asked, A and B, or all of the above. And the answer is kind of vague. The real answer is just A and B for the most part, because we prefer not to be only called at the end of life, although we definitely want to be there if that's when they need our help, and that's when they'll accept it. Chronic pain is actually a lot of palliative care clinics trying to exclude that. Not always, though. There are some pain scenarios that we take care of, and we provide something that's a little bit different than the regular pain clinics, mainly because you just bring up opioid management is a big hot topic recently, because it's just challenging with the dependence and all of that stuff. So good. The answer, yeah, would mainly be A and B, but can be a combination of all of them. This one also, palliative care co-management is similar to the relationship between a cardiologist and a primary care provider. So true or false? Again, I shouldn't do this, but the answer is kind of both. It's true in that we want to have a good working relationship with the oncology group and any other providers that refer to us. It's false in the sense that I use this example because sometimes cardiologists, you don't really communicate with that group very much. So sometimes there's very little communication. All it is you read their note because they did this, and there's not as much communication. So the way that this would be false is if it's a scenario where you don't communicate very much. So if that makes sense. Benefits to palliative care consultation, and we kind of already heard a number of these things, which is reduced general medical costs. We all hear that. That is why palliative care exists in hospitals. Cost avoidance, that is the main model financially that palliative care was built on. So that's an obvious answer. Prolonged survival, that is true. There have been some other studies that have not shown the prolonged survival. So I guess take it with a grain of salt that the one study that is the one that's been shown every time. There are other studies that don't show that same survival benefit, But in general, they still show the rest of these things, which is improved quality of life. Actually, this one's interesting, reduced provider burnout. So reduced oncologist burnout, reduced cardiologist burnout, reduced provider burnout in general, which is an interesting topic. So this one is all of the above are true. So the goals, we kind of already have listed those. When should palliative care be involved? What is co-management, and what are the benefits of co-management? So let's move on and dive into this. We always said, it's funny because the next slide is very similar to, if you noticed, all three of us had the same slide or same diagram. This is one that Jody referenced. I like to describe this diagram as all hospice care is palliative care, but not all palliative care is hospice care. And it's really, really, really important to recognize that fact. And we'll go through that in a little bit, talking about these topics of co-management. But it's just interesting. It's just a paradigm shift to say when palliative care is appropriate. And it's usually just when symptoms or stress or caregiver and family burden become so overwhelming because of this person's chronic illness that they can't handle it, or you can't handle it as a provider. Those are times when we should be involved. Sometimes it's up to 3 to 5 years before someone actually passes away. It's interesting to see this continuum. I call it a continuum because they should be the same. Unfortunately, Medicare regulates 6 months, and that's why we're excited to go to India, because we don't have to divide it between hospice and palliative care. It can actually be a continuum, and should be. If even if a person is referred to hospice a week before they die, if they received adequate palliative care throughout that time frame, that might not be a terrible thing, although they would miss out on all the support and benefits that Jody mentioned with regards to paying for their medications, their durable medical equipment, all of those additional benefits that a hospice brings. So that's an interesting discussion. So I also pulled this one up, and interestingly, I pulled the one from CAPSI. This one comes from the CAPSI website, which you've probably seen. The two they had, which is interesting, and I wanted to point this out, the difference between the two slides that they both had. This one has kind of a wavy line, which is interesting, right? Sometimes in a heart failure patient, the palliative care team is involved significantly when they're in the ICU because of an exacerbation, or COPD, same thing. And then they start to, then we back off, and then we come in more aggressively and then back off. And it's interesting to see that dynamic, which should exist if you have adequate access and good palliative care. So this is a slide that I want to make sure that we talk about as well. This describes the palliative care IDT, and it's interesting that Jody pointed out. You see the number of, it's not just one person in the center of the circle, it's a bunch of people, right? It's the patient and their family and their friends. And so it's interesting to see that that's the focus. Then you see all the providers that are involved. And so that's why I ask, who has access to true high quality palliative care? It's interesting. If you can't list some of these providers on your list, you might still not have full access to all that palliative care can provide. So it's interesting to think through this. So the main symptom management in blue on the upper right it includes RN, pharmacist, nurse practitioner, physician, and that's important. One of the ones that we have great access to that I'm really happy in our clinic is we have a dedicated pharmacist full-time in our clinic. So our patients come in, and our patient's schedule, they see the pharmacist first for the first 30 minutes and only him. So he actually works in a clinic and sees patients in their rooms just like we do as physicians. And that's not a very common scenario. But he sits down and he goes through all the medications, prepares the list of all the interactions, and sets up a scenario where you can pick the patient's symptom, you can make sure that no drugs are causing that symptom, and then work through de-prescribing, which is a big push, at least in our area, because most of the time when patients come to us, they have their list of 25 medications, and it doesn't go very well because there's so many interactions. So pharmacist is actually very, very interesting piece of this puzzle. If you're in a scenario where you don't have access, you might consider just calling your pharmacist and asking those things. Most of them will be very interested to participate if you ask them, which I've done as well in different settings in our community. Pharmacists are actually very curious and very, very helpful. If any of us that are providers remember how long our pharmacology rotation was in training, very, very small. I think mine was 6 weeks, and they try and cram it all in there. And the pharmacists spend many years studying, and they actually, I know many of us providers know a lot, but they always know more than we do. And it's interesting to recognize that because they're extremely helpful if you ask the right questions. Then you just go around this circle and you can see that there's chaplains, social workers, psychology, respite care in skilled nursing facilities that helps the caregiver burden symptoms, and then other volunteers, and you just go around and you can see the vast majority. And what's interesting is high quality, high level palliative care involves that whole group at some point. And so I wanted you to see that because this is the standard that we should be shooting for at some point, which is great. But we recognize very clearly not every area has access to this kind of palliative care. But when you do see it and when you do have access to it, it's wonderful because of how much support you receive. So let's move on just a little bit so we do well. So what is palliative care co-management? I'm going to use a couple of cases. And again, oncologists beware. This is a fellow that I take care of, wonderful, wonderful man. He's 93, has myelodysplastic syndrome that was diagnosed late in his life. Actually diagnosed when he was in the hospital with severe pancytopenia. His hemoglobin was 5.6, and he had pneumonia on top of that. So he's very thin, elderly man, was in the hospital, came out of the hospital, said that was the worst experience of my life. I never want to go back. And when I consulted with him, the first thing they put in front of me was the post form saying, please don't make me go back to the hospital. Very interesting scenario. And it's interesting that basically when he got referred to me, the thought was he needs to go on to hospice, right? This is a guy that is likely meets hospice criteria. As I've watched him, he probably does. He got transfused, and then within 4 or 5 weeks, his hemoglobin was back down to 7, and he just keeps dropping. So very, very severe case of pancytopenia. His bone marrow is not doing its job. And he doesn't have options for transplant, decline transplant, any of those things. So that's an interesting case. So this is one type of co-management, which is call the palliative care team when it's near the end of life. And that's when they can be useful. And yes, we want to do that, absolutely. But as you've seen, there are times when we would like to be involved much earlier, if possible. The next case is actually a very interesting case that I really love to point out. So this was a 61-year-old lady, stage 3C, I believe, rectal carcinoma, had resection, has a pouch, was going through, I think she was on cycle 6 of Xeloda and oxaliplatin, and she had to stop therapy because she couldn't tolerate it. She was so nauseous, so dizzy, so many symptoms, she just could not do it. We brought her into our clinic and put her through our system, and she met our pharmacist, our nurse practitioner, our social worker, everyone. Interestingly, and you can see down here, she came in and we recommended a number of hydration. We adjusted her blood pressure medicines. Our pharmacist recognized that Xeloda increases the levels of losartan in patients' blood, and she was just getting hypotensive, and so she was severely dizzy, and then the nausea got worse, and everything else got worse, and she got flushed, and she was just being over-medicated with blood pressure medicine, and she has a very treatable disease, and so we stopped the losartan, adjusted her other blood pressure medicine, recommended certain hydration protocols, and she hasn't come back. I saw her once, and she's doing great. She's completing the treatment. We've checked in through just by phone calls, and it's a very interesting scenario, and that's one of the benefits, especially for the oncology group, is having that pharmacist involved is very critical. It's a very important piece. But this is a case of co-management throughout an illness. So you saw the wavy line of when we're involved. We needed to be involved soon after diagnosis, and our role was quite high. Now we're way backed off, and we don't do that much. If she happens to relapse or doesn't achieve a remission or something like that, we definitely have a relationship with her and can be involved. But good scenario of when and how the palliative care teams can be involved. The last one is basically the scenario of a young female that has advanced stage breast cancer, gets treated and goes into remission, subsequently relapses a year after with widespread metastases, and starts the second round of treatment, becomes so ill and unable to tolerate it that because we were involved at the beginning, she chooses to go on to hospice. And interestingly, on to hospice for 5 months, which is interesting, right? That would be ideal. She receives the full benefit of the hospice services in order to care for her and her family. So this is a co-management at diagnosis in a severe illness. So that's kind of what those three scenarios are interesting to think about. You can be involved right at the end, in the middle, throughout, or right at the beginning. And when we are involved at the beginning, that's when the patients receive the fullest benefit. That's when I would say for the right kind of patient, their survival would be longer. One study that I present in other cases when we talk about pain management, it actually indicated that adequate pain management helps people live longer because they're not so stressed. And that's an interesting scenario, possibly one of those answers to the Temmel question of why, that we've talked about. Why is it that people live longer? So it's a great case. So then lastly, I just wanted to, this study that is from Jennifer Temmel's on this study, but it's called Stronger Together, and it talks about, it was published in 2016 in December, so not too long ago. And these are some of the definitions. So the Center to Advance Palliative Care's Improving Outpatient Palliative Care Project, which is, like we said, we're trying to get away from just inpatient palliative care to doing it in the clinic setting. They define co-management as occurring when oncologists and palliative care clinicians jointly make decisions and recommendations. So that's actually probably not the case in hardly any scenario right now. I'm not sure where that happens. In my own clinic, we are developing very strong relationships with the oncology groups, but I know that is variable across the country. Ideally, it would be the oncologist, the palliative care doc work together to make decisions, and I think particularly it's important when you're in the second, third line regimens of treatment for malignancies, just because that's when those decisions are kind of so-so, and a lot of it you all have mentioned as oncologists, you kind of lean on the family to say what can they tolerate or what can they deal with still with relation to side effects and all of that stuff. And then it says, although early involvement in palliative care is associated with better outcomes, co-management can occur at any time in the disease trajectory and in the inpatient and outpatient settings. Successful co-management requires close collaboration between care providers and, in the outpatient setting, clinic co-localization with the palliative care clinic located within or near the oncology clinic, which is interesting. I went down for some training at UCSD, and that's how they work. The palliative care provider just shows up at the oncology clinic and just kind of follows along behind the oncologist and meets the patients and does a very, very seamless co-management. So there's different levels of this possibility that exist, and it's important to see just where they are. The one that gets in the way of this is the group that I'm working with, it's always a struggle between the hospital and the administrative staff and the quote unquote bean counters that want to make sure the business is viable versus doing what's necessary for the patient. So you have to see where your administrative leadership is in this process. In our situation, that we can't just follow along because it's hard to bill in the same location and all of that stuff. The billing and all of that gets confusing. So it's hard to manage all of that. But that would be possibly the ideal. Where I've seen it work really well down at UCSD is that palliative care provider just follows around in the oncology clinic, and it's really nice if that can be worked out somehow. And then lastly, this speaks to the benefits of co-managing at a high level. So this is the kind of the conclusion of this study that was published, and you'll see it in the references, but it's a quick read, easy to talk about, or easy to see what they're trying to point out. But co-management allows clinicians to deliver comprehensive care to patients with advanced cancer. It requires a strong partnership and a shared understanding of each other's subspecialty. So one of the key topics in this study are understanding what each other does, because a lot of times any provider that we do, particularly I think oncologists are way further down the road of understanding what palliative care providers do than probably cardiology is one of the outliers, at least in our community. Pulmonologists are very good at it because they experience it in the intensive care setting. But understanding what each other does is very important, and that's why localizing in the same area, having open, continuous discussions among providers is really important. A shared framework for how patients cultivate prognostic awareness, and Leanne mentioned this concept of prognostic awareness. This study, you'll see, if you look at it, it shows a kind of one of those, a pendulum, and there's some where there's hope versus there's reality, right? And the patients swing back and forth in this situation, and it's a fine balance to figure out where to put them and how to manage them, and it's very patient specific, and that's where the art of palliative care comes to light. But it's very interesting to see where patients are in that pendulum. They want to maintain hope, but they need some reality. And if the oncologist and the palliative care provider are aware of that pendulum where they swing, they can find the sweet spot and help them process their prognostic awareness appropriately, which is, it's hard. It's just plain hard, I would say, in general. But important, and that's why co-management is so important. And then a shared vision for the clinical goals between the providers. I think that's important. Co-management works most effectively when clinicians provide consistent message to the patient and are grateful to the complementary skills of each role and subspecialty. I mean, working together and just having mutual respect, I think that's important. And then lastly, through co-management, even the most difficult clinical circumstances, palliative care and oncology clinicians can provide patients and families with high quality care. And that's for sure. That was their conclusion in this study. And I think that's all of our goals. It's a matter of recognizing our demographics, what's available in different areas, and being able to take advantage of what you have, but seeing both sides of the picture is really, really important. And that's why we talk about co-management. So, that's all I have to talk about today. So let's move on to the question panel, if that's okay, and we'll just open it up and let me know what questions you have.